theme 9 is therapeutic and diagnostic systems, devices and technologies, and clinical engineering. My name is Nick Schbat, along with my co-chairs. So I am a theme co-chair, along with my co-chairs Doran Panescu and Mike McShane. We have the pleasure and honor to introduce Dr. Richard Roa, who will be the keynote speaker. Dr. Roa is currently a senior project manager with the Philips Healthcare Hospital Respiratory Care Division. Prior to this position, he served as Senior Director of Product Development at Space Labs Healthcare and as Vice President of Engineering at Protocol Systems. Before entering the healthcare and the medical device development business, he served as a Director of Clinical Engineering at Baylor University Medical Center in Texas. Dr. Roa obtained his PhD and master's in electrical engineering from Washington University and bachelor's in EE as well from the University of Missouri. It's my pleasure to introduce Dr. Roa.
All right, thank you. As Nick mentioned, I spent some time, actually I've spent about 20 years in clinical engineering at Baylor University Medical Center, and had a chance to learn a little about medicine, running to the grand rounds and so forth, and got a chance to see how ventilators were used to save lives, and was always very impressed with that, and thought I understood ventilation pretty well. And then I went into, when I left clinical engineering, went into product development, worked in monitoring and telemetry for a while. When about almost 5 years ago I came to Philips, I got into ventilation. And I remember telling one of the guys there that, yeah, I don't know that much about ventilation, but I'll probably pick it up in about 3 or 4 months. And they laughed and said, no, it takes a little longer to learn ventilation. And it's been almost 5 years, and I'm probably halfway to knowing it. So with that understanding, I'm not the world's expert, but I'm going to give you an engineer's view of kind of what I've learned about ventilation. And it's going to be a little more from the standpoint of engineering. I like to approach engineering from what are the problems we're trying to solve first, as opposed to, I got a cool technology, what can I do with it? So I'll be probably spending a little more time on what I think are the current problems we see in ventilation and what the current approaches are to working with them. So let's see with that. So this is what we'll do. I'm going to do a really quick run through of the history of mechanical ventilation. I'm going to run through about a couple years of education in about 4 minutes. I'll call that Mechanical Ventilation 101. Those of you who know ventilation, you won't learn anything new. Those who don't, hopefully I'll at least give you the terms I'm going to use for the rest of the talk. We're going to get to the primum non nocere. I think of that as the first rule of medicine, and it's one of our great challenges throughout medicine. Breathing in synchrony, well, that'll be one of, I think it's one of the ones that's underestimated as a problem in ventilation, and it's one that we're making great strides in. We'll talk quickly about work of breathing, and then we're going to talk a little bit about how we close the loop. I'm not talking about PID controllers and all. We got lots of those inside the ventilator. I'm more talking about the entire clinical, how do I close the loop to make certain I'm treating this patient properly. We'll talk about some of the new technologies, or not that new, Heliox, Nitric Oxide, what we're doing with those, ECMO, and the kind of more recently the extracorporeal carbon dioxide removal. And maybe we'll do a quick wrap up and have some time for questions. So I'm going to run through a quick history here. You first saw some ventilators. Draeger made something, I think it was called the Pulmicort, back in like the teens or 1920s, very, very early. It was kind of a rescue positive pressure ventilation system. And it had some use, but there was a lot of problems with barotrauma, volutrauma, and they were finding they were hurting people more than they were helping them with it. Somewhere around the 30s and 40s, there were a number of polio epidemics, and all of a sudden we needed ventilation pretty badly. with the bad rep that positive pressure ventilation had gotten, people went to negative pressure ventilation. So you can see here the famous iron lungs, that a few of them are still around. But, and then on the right there, you can see kind of the principle of it. I mean, to pull air into the lungs, the person's paralyzed, so their diaphragm's not going to pull down, their intercostal muscles and so on aren't pulling up, so they can't breathe. So we're kind of doing it for them, and we're just removing the pressure outside the thorax so that you have a pressure gradient that'll pull the air in. It worked, and it worked good for long term. The patient, but as you can see, it's not real easy to work with the patient here. You're going through some little portholes there. In the 50s, positive pressure ventilation began to get going again. They had a little better understanding of how to manage it so you don't harm the patients. Forrest Bird developed some of the earliest ones. So there's I think everybody's worked in a hospital has probably seen the Bird ventilators. And then up into the 60s, we kind of got the first electrically driven ventilators. Of course, we see all the controls on there. So basically everything you were setting, you just turned the dials and set it up. So the Puritan Bennett MA1 is a good example of that. And it wasn't really until the 80s with the Puritan Bennett 7200, I guess, what was that, 83. That's really, I think, when we can say we entered the era of modern ICU ventilation. Microprocessor controlled, you can control things with software, you can continually upgrade your control circuits and proportional solenoid valves. All of this kind of got perfected. So since then, I don't think there have been any quantum leaps. It's been continually improvement on that. So from that standpoint, when we look back, what I think of as modern critical care ventilation is about 30 years old. That's remarkably young. So I'll say it's no surprise to me that in my mind, I see this as a very evolving area. I see it as an area that we're still learning, and you'll see that as we move forward with this. I'm guessing in 30 years, it'll look totally different than it looks today, because we're still, as you'll see, struggling with figuring out what are the right modalities, what are the right technologies to use for different patients, how do I know which patient to treat with which modality, but the only way you can do that, of course, is with randomized controlled trials. Those are very expensive, very difficult, and as you probably know, every patient, every hurricane's different, every patient's different, so you get, you can say, I got 50 COPD patients. That doesn't mean you have 50 people with the same condition or the same comorbidities and all the others. So it's incredibly difficult to tease out how do I know what is going to really work with this patient. So we're still at the point that we're trying to provide as many tools to the clinicians as we can. At the end of the day, I think ventilation requires really highly skilled clinicians. So going into mechanical ventilation 101, for those of you who forgot, we have lungs, we have bronchi that come down, they bifurcate and then rebifurcate and bifurcate and bifurcate, and I can't remember how many times. It's a surprising number of bifurcations before we get down to the alveoli, which is where the actual gas exchange occurs. The problems that we see, atelectasis is basically alveolar collapse. So over here I'm trying to illustrate, this is what the whole point of the lungs is perfusion. So we're getting, ventilation is getting the air in and out of the alveoli. The perfusion, we're getting the blood flowing through. If all is going well, we've got a nice membrane there that is permeable to the gases. We get gas exchange and some level of equilibration. The blood gives up the CO2, takes on some oxygen into the hemoglobin, and life is good. We have a couple situations where it doesn't work so well. The first one there on the left that's a shunt unit. So we call that shunt because the blood's moving just fine. It's going from the right heart through the pulmonary circulation to the left heart, but it's passing through areas that aren't ventilated. So I'm not getting the exchange. The normal unit is shown in the middle. On the right, I have a dead space unit. Now in this case I'm talking about alveolar dead space. So I have an alveolus that either due to collapse or blockage or other means even, simply isn't, I'm sorry, I'm getting that backwards there, dead space unit on the right. The pulmonary is blocked there. Sometimes this is because of hypertension, pulmonary hypertension actually squeezing off those capillaries. So you might have a nicely ventilated alveoli, but no exchange because the blood's not getting to it. Excuse me. So about the only other thing I'll cover, just the terms, and there's various terms people use, but triggers generally is what we call the initiation of the inspiration by the ventilator. So the ventilator is deciding this is the moment I'm going to begin inspiration to the patient. Excuse me. And then cycle is where we terminate the inspiration when we are going to allow the patient to exhale. That's a bad term. Positive end expiratory pressure, respiratory therapy is full of acronyms, which is my bane. But PEEP is one everybody needs to know. It's the positive end expiratory pressure. It's probably the most common value of interest. And there's kind of two kinds. There's intrinsic PEEP, which is really unintentional. And this is where if I'm trying to breathe at a rate and I'm not giving myself enough time to expire before I give the next breath, then I haven't completely emptied the lungs. So in various obstructive or restrictive diseases where it's hard to exhale, like asthma or something, it's called breath stacking. I haven't really exhaled before I do the next breath. I haven't exhaled before the next breath. So as you get to kind of a steady state with that, you have a certain intrinsic positive end expiratory pressure that's maintained in the lungs. The other extrinsic PEEP is we deliberately actually like a certain level of PEEP for reasons I'll get to. So that's where the ventilator is deliberately making certain, at the end of expiration, I'm still going to maintain a certain pressure in the lungs. So jumping on, now that you know all about ventilation, I want to talk about the things that are the problems that we faced. And these are the problems that started, when we started positive pressure ventilation about 50 years ago. And we still are wrestling with them today. Probably the first one we hear about all the time, ventilator-associated pneumonia, primarily basically caused by, I've put an endotracheal tube down, I've put a little cuff around it, and so I have a good seal. And so now any secretions just sort of end up at the top of that. They can leak through, they get down into the lung, and I contaminate the lungs. And this is usually a sick, compromised patient. So, what do we do about that? Really, the best thing you can do is minimize ventilation time. Everything we're trying to do with ventilation, where possible, is to minimize ventilation time. We want to use ventilation as a bridge, let them get healed, get them off it. Also, I'll talk about non-invasive ventilation for a moment. I have to give full disclosure, Philips is the market leader in non-invasive ventilation, so we kind of like it. But so I actually started to leave it out, but then I realized, wow, that's really wrong. This is, it really is one of the modalities that I think we'll see more and more use of. There are protocols, ventilator-associated pneumonia protocols that hospitals use, keeping the head up, suctioning regularly, and the use of these continuous aspiration of subglottic secretions, another nice acronym, the CAS tube, which is basically, it has an extra little lumen in it that's always indwelling, and it's continually kind of suctioning, or you can suction out just above where the cuff is. And this has been shown to have some positive effect also. Yeah, going into non-invasive ventilation, now instead of putting the endotracheal tube or the tracheostomy tube, we're going to go ahead and find some kind of an interface, some kind of a mask. It can be a full face on the right, or nose and mouth, or there's various interfaces that are done. So obviously this is a little more pleasant for the patient. You're not having the problems associated with ventilators, having the tube down. The applications, the benefits of it, I mean, it's easy, very easy to put on and off. You can be intermittent. I mean, basically, if you're invasively ventilated, you can't decide, well, let's go without the invasive for a while and then we'll go back to it. I mean, you can't be putting these tubes in and out quickly. but you can take the mask off and put it back on. Patients are certainly more comfortable, reduces the need for sedation, and I'll get to that a little more. And you can speak, you can swallow. You don't need a nasogastric tube with invasive ventilation. It's common. You normally will put down a nasogastric tube as well. There's no need for that. And you can cough, which you can't do when you're invasively ventilated. It avoids the resistive work imposed by the endotracheal tube, and you avoid a lot of complications. So I'm not going to get the aspiration. I'm going to get less nosocomial infection. I won't claim none, but you definitely reduce that. And having the cuff in the trachea puff, inflated to the level where it's not going to leak, certainly isn't real happy for the bronchi down there. So you get a little bit of local trauma, injury to the hypopharynx, larynx, and trachea. As a matter of fact, one of the things they sometimes find, you'll have a tube down there and there's a certain resistance to the tube. You pull it out and you figure, oh, well, now I won't have that resistance. Well, now it's all inflamed and swollen, and even after you pull the tube out, you still have the restrictive bronchus there until that recovers. So it's so wonderful. We should be using it all the time, but we certainly can't use it in certain cases. We don't use it in apnea, shock, patient who's unable to protect the airway, any patient that's really rapidly deteriorating, significantly altered mental state. I mean, it's suitable for patients that can kind of participate in their own care, not so much for the patient that's obtunded. And you need to be able to fit the mask. Sometimes facial trauma, or even people with very unusual facial structures can be difficult to fit. The other one we run into is ventilator-associated lung injury. Primarily, there are two areas there. One is the alveolar overdistension. You simply are stretching it too much. And let me digress for a moment. One of the reasons these can be so difficult is the lung's not completely homogeneous. You'll have some parts that are diseased more than others. So I'll have one part that's actually very compliant. It's very easy for me to inflate it. Another part that's very hard. So if I'm trying to put enough pressure and volume in to inflate the part that has collapsed, that's atelectic, I might be overinflating the more normal part. So I'm kind of fixing one part of the lung and I'm breaking the other. So it really, I guess a common theme in this is you're walking a tightrope. I mean, with reasonably healthy patients, for some reason I got to bridge them over. The ventilation is very easy. It's not that big a trick. But when you get into your critical patients, there's very many situations, and we'll talk a little more about that, where you're really walking the tightrope. I mean, the therapeutic range is very, very small. If in order to get it effective, I got to do this much. If I go this much higher, I'm hurting the patient. So I have a very tight therapeutic range, and that's one of the challenges with a very critically ill patient is how do we stay in that range. And I mentioned, permissive hypercapnia. So, I'm sorry, let me jump back to the ARDS-NET protocol. ARDS is acute respiratory distress syndrome. The lungs have been damaged. They end up being very stiff, very difficult to ventilate. This is one of the challenging patients. So there's a protocol that's found that people were pushing them too hard. They were actually causing damage. They're now recommending something like 6 to 8 milliliters per kilogram as a tidal volume for these people. And they're finding if you can keep it there, you have less damage. Unfortunately, you find some patients that's not adequate to ventilate them. So one thing you find then is permissive hypercapnia. I mean, in this balancing act, we're balancing, what we're doing for the patient, what harm we're doing for the patient. Permissive hypercapnia is actually one of the techniques that's used where we may say, I really want this guy's SpO2. If any of us did it right now, we'd be 98, 99. We want our patient to be 95 or something. Well, we might let them go to 85. We might let them go to 88 or 90. We're going to let them go down a little bit. Now, I got to be watching the acidosis that happens with that. But again, it can be the right balance I don't want to damage the lung, and this patient can tolerate some mild hypercapnia. The other damage we see is repeated alveolar collapse. And what happens here is, part of the lung collapses. another part doesn't. And then so I inflate it and I bring it back up, and then it collapses again, and then it brings it back up. Sometimes this is called shear stress or shear damage, because you've got adjacent areas, and one of them is opening and closing, and one of them staying open. So we're getting shear stresses between them. And this is actually one of the causes of damage. So this has led to the whole concept of open lung ventilation. And I'm going to describe that, and I'll say, though, this is another area that if you were to say, okay, what is the best practice for open lung ventilation, if you know what that is, let me know, because there's still a lot of people doing it different ways. I think we're still trying to work it out. Basically, what we're going to do with open lung ventilation is we're going to try to put just enough pressure on to open all the atelectic areas. So I now have the lung open, so everything's being ventilated. And then I'm going to maintain the PEEP so it doesn't recollapse. And then what I want to determine that PEEP as low as I can, because we don't want to be overpressurizing the lungs, but I want to have it at a level that's going to keep that lung open. So there's a number of methods of doing this. I'm going to show you one method here real quick. We'll just run through it. What I've got here is, I don't know if you can, I guess I can see it best over here. Okay, on the ventilator here, we're looking at a trace. So actually, here we go. So if you can see this little line right here going up and down, that's where it is right now. So right now it's at a level of a PEEP of 16. And over here, we've reached a baseline. We're monitoring the patient's CO2. We're actually doing what we call volumetric CO2. We're measuring the CO2 concentration continuously as the patient expires. And so you can see that here. And then we can integrate that so we know exactly how much CO2 was given in that breath. So here I am with a PEEP. I've been running at a PEEP of 10. And I just increased it here to 12 if we're looking back in time. And I let it sit there for 10 or 15 minutes, and I don't see any change in the CO2 excretion or gotten out. Now I increased the PEEP to 14. And now after 10 or 15 minutes, I see, okay, I'm actually getting some increase. I'm getting more oxygen or more CO2 coming out, because I'm popping open some of the alveoli now. So let's take it up to 16, and I find a continued rise. So I'm still opening up the alveoli. So let's take it up to 18. Each of these times we're giving it a nice 15 minutes or so. Now I actually suddenly find something bizarre, something that's paradoxical. All of a sudden the CO2 is dropping back down. What's happening is, if you remember the perfusion, I'm actually starting to squeeze off those capillaries now. And so I'm probably ventilating, but I'm not getting the perfusion, so I'm not getting the CO2 out. So I've now taken it a little too far, but by now I'm convinced I've popped all those alveoli open. So I'm going to bring it back to 16, and this is the PEEP that we're going to run the patient at. So that's kind of the idea of open lung ventilation, and this has been, I think, a pretty significant advance, but it's still one that's being continued. Oxygen toxicity, that's another way we can hurt the patient. The one everybody knows about, I think, is retinopathy of prematurity. Too much oxygen, you get the retinas end up getting some damage, it detaches, you can end up with blindness, and there was a lot of publicity about that a number of years ago when that was happening. There are a lot of other things that cause retinopathy of prematurity. I mean, just controlling the oxygen isn't necessarily going to prevent it. Prematurity, hypoxia, all of those can lead to it. So it's one of those. Hypoxia and hyperoxia can both damage it. The other thing with neonates, you typically try not to run oxygen on a neonate above about an FiO2 fraction of inspired oxygen of about 60 for any length of time. For a very short time as a rescue you can, but for any length of time you wouldn't. One of the things, if you've been ventilating an infant or a neonate at a level of, say, 50, if you drop it rapidly, you can really tank them. One of the problems with neonates, they're not like adults. Adults will trend. I mean, if you're really watching, you'll see them trending and you realize, this guy's going downhill, I need to do something. A neonate, I mean, they just go. So if you take a neonate and they were at 50 and you think, let's try them at 30, you drop that to 30, they go hypoxic, the lung develops a shunt. You can take it back up to 50 and you're not going to pull them back. You can lose them right there. So it's another of the things that you have to be very careful. They call it flip-flop. Typically, if you have a neonate, they're stable. It's something you're going to try to start weaning them off oxygen. You take it 1 or 2% at a time. You wait, you watch. Neonates really got to be watched closely. The other thing is, even with adults or anybody, formation of reactive species leads to the membrane damage, the permeability changes, and you start getting fluid into the lungs. So even with adults, everybody, if you stay too high too long on oxygen, you're harming the patient. All right, let me get to breathing in synchrony. This is one I like, so I came up with that little picture on the right. I like the idea of kind of the patient. One of those is the patient, and the other is the ventilator. You can decide which, but I like the idea of if we do this right, they're in a dance. And they're dancing in harmony, just like those divers at the Olympics when you had two guys going off in perfect harmony. And this is a good place to introduce the equation of motion. This is everybody respiratory does the equation of motion. Basically, what I'm going to call P airway, this is the applied pressure at the airway. So for you and me, that's 0. I mean, nobody's blasting air into our mouth right now. P mus is the pressure. That's that negative pressure that's developed by the muscles, the diaphragm and the chest. And so in a paralyzed patient during surgery, for instance, P mus is 0, so they're being ventilated by a ventilator, so it's all P airway. So what the resistance that's overcome, well, there's flow, there's the resistance part, and then there's the volume divided by compliance, basically the effort it takes to blow up the balloon. So for normal, healthy people breathing on their own, airway is 0, no problem. For anesthetized, paralyzed patients, P mus is 0. I won't say no problem, but frankly, from a ventilator standpoint, that's I won't say no-brainer, but if you had to design a ventilator for a patient like that, anybody could do it. It'd be easy. The fun begins when you have both. I mean, I have a patient that's not zonked out. I don't want my patients zonked out. I don't want them sedated. I want them awake and working to try to get healthy. So when I have somebody that there's some P airway there, and the ventilators they're working together, challenge is how do I pull that off? And that's the rest of, if you're getting into control systems, this is where it gets fun. So P mus represents what the patient wants to do, either consciously or unconsciously. P airway represents what the ventilator is doing. So as I mentioned before, trigger and cycle. The patient has his idea of when he wants to trigger and cycle. The ventilator has its idea. If they're not in harmony, we have what happens here. So there's kind of two kinds of dysynchrony, I think, of phase dysynchrony and flow dysynchrony. Phase is real obvious. I mean, I want to take a breath and the ventilator's not doing it. It's not giving it. And I pull harder and harder, and then finally the ventilator does it. And now I'm trying to exhale, and I'm halfway through my exhalation, and the ventilator's pumping another breath into me, and it's like, God. And so I'm fighting the ventilator, and this is probably one of the primary causes of what I think of as unnecessary sedation. It ends up being necessary because you can't have the patient doing that, but I'm sedating a patient now because they're fighting the ventilator. And the only way I can get them to stop is to sedate them. And this is one of the huge problems that is still unsolved, in my view, in ventilation. That's why we work so hard to figure out how to get this synchrony going. The other one is flow dysynchrony. I'm taking my breath. The ventilator's giving me this little slow breath, but no, I want to take a breath, So it's not helping me. So that's another kind of dysynchrony. The benefits of synchrony. So as I was saying, certainly patient comfort and reduced anxiety. I don't know if any of you have been on a ventilator. I haven't either. If you have, I've talked to plenty of people who have. It's not the most pleasant experience. And just putting, we all breathe on the masks, and just, basically plugging yourself up so you're forcing yourself to breathe on a ventilator, unless it's a very good ventilator, which we do make very, very good ones. But unless it's a very good one, even with a very good one, it's not comfortable. And if that ventilator is not working with you, it's working against you, you're really a very anxious patient, and you don't need that. So less need for sedation, and really the whole sedation delays the amount of time how long it takes me to get the person off the ventilator. So again, we're going to have a higher level of ventilator-associated pneumonia, more trauma, plus we're going to get to another problem of if you stay on a ventilator very long. So with phased asynchrony, that's due to improper triggering and cycling. Intrinsic PEEP is a very common reason for that. Improper sensitivity settings on the ventilator, and so we can get to where it auto-triggers. If the sensitivity is very fine, it's actually auto-triggering even off of cardiac oscillations that it picks up. So the mitigations to that, there's a new one out. Ideally, if you could really do it, what you want to do is, what is the brain trying to say? So that's the neurally adjusted ventilator assist. I think that's one of our competitors, but we have to admit this is an outstanding technology. It's what they're doing is they're going to drop a little probe down the esophagus so that it's picking up right around the diaphragm, and it's picking up the electrical signal. So it can pick up when the diaphragm is trying to pull, or when it's going to relax. From that, you can get very good synchrony from, I can now get the ventilator in synchrony with what the patient's trying to do in very good time. It's still, I'm having to put this probe down, and it's finding, so it's a little more invasive, it's an expensive method. It's finding its home, I think, in neonates. That's where they're finding that this is working out quite well. In Teletrack, I apologize, that's one of our trade names. But that's our method of using an algorithm largely based on the equation of motion, where what we're trying to do is understand the compliance and the resistance, the various factors in that, and basically estimate what is the P-mus. That's what we're really doing. If we measure everything and we use the equations, we think we can estimate what is P-mus from the signals, and we're getting pretty good results with that. So the goal would be to try to get to what the gold standard would probably be actually putting the electrodes down there, see if we can get the same effect non-invasively. And we're not the only company that's doing that, obviously. So everybody's working along that line, and I think with some good results. Flow to synchrony, Flotrack is our trademark, but basically this is the method that if the patient says, I want some more, you can set it to where, okay, if they demand more, we're going to give more. We'll be responsive to the patient. And then there's, because of trademark names, there's PAV, PPS, PPV. These are all things that are based on the equation of motion. They're all basically based on the equation of motion, estimating how much is this patient trying to push, and then you kind of set it, I'm going to give 50% of the total work here for the patient. So if I know they're trying to push this hard, I'll support them. So if they're trying for a small breath, I'll give them a small breath, a bigger breath, I'll give them a bigger. So it again improves the synchrony. So using all of these, the synchrony has gotten a lot better than it has in the past. Just real quick, work of breathing. So I'm going to start building up a Campbell diagram here. So you can draw these different ways, but I'm going to draw it along the volume and then the transthoracic pressure on the vertical. So basically, if we took a breath very slowly so that there's no resistive element, as air's coming in, the transthoracic pressure goes up. So this is just the elastance of the lung. A lung with a lot of elastance is stiff. I mean, that's the slope of the curve, is the elastance. Compliance is just the reciprocal of elastance. So if I wanted to do work of a breathing on the inspiration, it's just I just integrate under that. and I have the work of breathing if somebody was taking a slow, gentle breath with no real resistance. On the exhalation, that's passive, so basically there's no work. There shouldn't be any work unless in an extreme restriction where you're actually having to push to get air out. Normally, though, we're breathing fast enough that there's a certain resistance. So, whoops, here we go. So the breath kind of goes like this. I'm coming up, and then I exhale out. So now we add in the red part, and we have the full work of breathing. So we have various ways of calculating how much the patient's doing in work of breathing, how much the ventilator's doing in work of breathing, which led me to this. So patients with low compliance and or high resistance, they're going to have a high work of breathing. And that's one of the reasons we put patients on a ventilator. I mean, they're just wearing themselves out. They don't have the strength to breathe anymore, so we're going to take that over. This is one of the problems of prolonged ventilatory support, though. It can cause disuse atrophy. And I just grabbed this out of a paper by Levine because it illustrates it pretty dramatically. There's a whole series of studies on animals that showed that the muscles of breathing are different from the muscles of locomotion. If you break your arm and put it in a cast, 6 weeks later you take the cast off, your muscles have atrophied a little bit. So yeah, but it takes a few weeks. What they found in the animal models was the breathing muscles, they start atrophying within 48 hours or less. I mean, it's very, very rapid. They were wondering if this is true in humans. It's not an easy study to do in humans because you have to find, basically organ donors and different things. But Levine managed to do enough of a study that pretty convincing that you're seeing the same thing in humans. It appears to be in humans. What I'm showing over here is the fast and slow twitch fibers. The amount of the control group is, the high numbers. The other ones are ones that had been on mechanical ventilation. I'm trying to remember, I think it was, none of them were more than 57 hours. I mean, we're less than 3 days. In 3 days, you're getting a dramatic reduction in the strength. So the more I have this person on a ventilator, the more difficult it's going to be to wean them. Weaning or liberation from ventilation is one of the other challenging areas of ventilation. So we want to get them off the ventilator. And I did want to mention there's something, there's kind of a new studies being done in this area that I think are really interesting. It's just as if you were trying to work all day long, you'd be exhausted and you couldn't do it. On the other hand, if you're fairly sedentary, but you go to the gym and you work out your muscles for 30 or 40 minutes, a couple times, 3-4 times a week, you can keep all your muscles well toned. There's some evidence that something like that can be done with these kind of patients. I have to take over the work of breathing for them most of the time, but maybe occasionally, 2, 3, 4 times a day, these things are still trying to be worked out. I'm going to make the patient work really hard. I have to have a patient that's going to work with me on this, but it's sort of like incentive spirometry. I'm going to make them, you got to push now. You got to really work hard. And initial results are looking actually very promising on this. So this may end up becoming another of the ways that we can keep people on a ventilator a little while and then still get them off. All right, I want to talk about closing the loop. I just have a couple things on that. This is kind of the way I think we practice. So let me try to walk you through this. If we'll start with the patient over there or the clinician. The clinician's assessing the patient. He understands what disease state he's in. He listens to the chest sounds, pallor, looks at his level of agitation, does all the usual vital signs. And based on that understanding, he sets an initial set of settings for the ventilator. And then once he's on that, he's monitoring. The ventilator is affecting the patient through the mode of ventilation, the flows, the pressures, how it's triggering, how it's cycling, what level of oxygen it's giving. It's doing all these things to the patient. The clinician is now not only still assessing the patient, it's now learning some things from the ventilator. The ventilator can tell him, hey, this patient's, here's his compliance, this is what it is, this is what his resistance is, here's his rapid shallow breathing index. It can give you all kinds of information about that patient. Based on that, the clinician closes the loop to the ventilator. Now, there's only so many clinicians and there's lots of patients. So A typical way would be you visit the patient every 2 hours, you assess, you make some changes, you go around on your rounds. If there's no alarms or anything, you come back in a couple hours and assess. That actually works pretty well in many patients. However, this is what I think might become future practice. What we're going to do now is we're going to take a closed loop algorithm that's associated with the ventilator, and we're going to say, now if we start with that clinician, they're going to not only set up initial settings, they're going to set up a plan. They're going to say, this is what is important for this patient. This is the balance. I'm willing to do this, but I won't go past here. Here's the guardrails. I don't want to do any more than that. But I want to optimize the pressure support, or I want to optimize the work of breathing, or I'm trying to optimize this patient's CO2 removal. Whatever is the most thing, what is the plan I'm working with? And that algorithm, that's my tight loop. It's working that not every 2 hours, it's working it minute to minute, second to second. So all of that's coming in. Meanwhile, the clinician is now, continually updating the plan, understanding what's going on. So one of the important things here, and I'm going to illustrate this a little more in just a moment, one of the important things here is the clinician has to know what that algorithm's doing. Clinicians, when they hear this, hate it. They don't want to do it. They all feel like you're cutting me out of the loop. I don't know what's going on with my patient, and it's true. It can be true. That's not what we want. What we want to do is have them understand the physiological status of their patient better than they ever did. And now, instead of just setting something and going off, they're going to set the plan for that patient. They're going to come back a couple hours later and find out, the thing's really having to work to keep him in this state. This plan's not really working. I'm going to revise the plan, not just a set of settings. So as you can tell, I'm a true believer that this is where we're going. But there will be, it is going that way. There will be challenges getting it accepted. Some of the ways that this is used, it's already being done in weaning. Weaning is a really tricky area. And there are a lot of, rather than having a clinician standing there every single minute, they have to be around, but automation of weaning is already getting used. Managing work of breathing, SpO2 control, there are a number of areas that you can do. So the benefits, the ventilator is continually responding to the latest needs of the patient rather than waiting for the next clinician assessment and setting change. And you can really maintain fine control. Fine control, I think, is underestimated. One of the things that back when I was in patient monitoring, and some of you are probably aware of, we all, with a diabetic or somebody whose blood sugar bounces around, we need to keep it within certain range. What has been found in a lot of studies is that if you keep it within this range, but it's kind of bouncing around inside that range, especially in ICU patients, you get much worse outcomes than if you keep it rock steady. So in studies where they say, we're going to really be continually measuring this person's blood glucose and we're going to be fine-tuning it all along, those patients do much better than the ones that you're allowed. You're bouncing within the legal limits, you might say, but that bouncing around is harmful. And certainly an example of oxygenation in neonates is an example where minute-to-minute control is really needed. So the risk, a colleague of mine likes the autopilot and wing icing. There was a famous air crash not too long ago where there was some fairly novice pilots, unfortunately, I guess, but the wings were icing and they were on autopilot, and the autopilot was correctly, changing the controls to account for the wing icing, and kept going. Finally, autopilot's just like that one over the Pacific because of the speed sensor going out. The autopilot finally gets to the point where it says, I can't control this airplane. It shuts off, turns on an alarm, and the pilot is suddenly confronted with, oh my God, what's going on? And in this case, they didn't make the right decisions and the plane crashed. I think the same thing is what the clinicians rightly are afraid of here. I mean, what's going on with my patient? What's going on with this? What we don't want to do is have the patient, the clinician, out of the loop on that. So the risk mitigation, of course, you're going to set up the guardrails. You're not going to have the thing go, automated and it just goes off and does whatever it wants with the patient. But the real key is how do we provide the clinician with information on the status of the patient and the ventilator, so it knows that, wow, I'm really having to push something to the limit that you've given me in order to maintain what you're asking, and something, this isn't working well. We have to make certain that happens. All right, I just want to give a couple words. Heliox, the indications. This is the helium-oxygen mixtures used for airway obstruction, asthma, COPD, chronic obstructive pulmonary disease. Any situations where you have a high work of breathing, you can reduce that. And also, if you need to get the aerosol medical aerosolized medicines into the periphery of the lung, it actually is more effective at that. So the density of helium is about 1/7 that of air. We can get into Reynolds numbers and all that, and laminar flow and all that. That's basically what's going on. You get a lot easier flow, much less resistance. Typically it's used in 60-40, 70-30, or 80-20 combinations. If you need more than 40% oxygen for the patient, then it's really not going to be effective because you're diluted out the helium so much that you're not really getting the effect anymore. And ventilators, in the old ventilators, they really had problems because, of course, the sensors and even the valves behave much differently with this. So you have to calibrate them for it. But it's found a number of uses. Nitric oxide with hypoxic respiratory failure, especially, again, this is in term and near-term infants is where this has found some benefit. It's a pulmonary vasodilator. You use very small amounts. So typically 6 to 20 parts per million is the level you use to get the positive effect. If you go much higher than that, this stuff's toxic. So, but there's a reasonable therapeutic range. You keep it around 6 to 20, and you can keep them on that for a few days. And it's one of those bridges. It'll get the kid through the crisis. Okay, I just wanted to finish up with ECMO. ECMO has been around for a while. Indication for severe acute respiratory failure, lung transplant, maintaining the person through lung transplantation, and especially, as I say, in ventilator-associated induced lung injury, avoidance of that. Some kids are born with meconium aspiration. Meconium is kind of the first poop that comes out. Really sticky, nasty stuff gets into the lungs, and the lungs just don't work. They just don't work. And it's really hard to get it out. So you can keep them alive while that's being resolved with ECMO. It's generally used with a veno-arterial, so it's really invasive. So it's been pretty much for us a rescue method. I mean, it's when everything else is going, I'm going to lose this kid. I don't know what else to do. I'm going to use ECMO. Now, more recently, they're finding more uses that it's not quite so scary to use. And the one that I'm most excited with, and I'm actually going to leave you with, is extracorporeal carbon dioxide removal. This can be done with a veno-venous shunt. So we're pulling out of the vein, we're going into a vein, and it's getting more and more, it's still very invasive, but it's not as dangerous as the veno-arterial method. And I'm not so much trying to oxygenate, I'm trying to remove the carbon dioxide. Oxygenation actually isn't that hard. It's the easier thing to do. I can oxygenate somebody with non-invasive ventilation at very low pressures, very low tidal volumes. But the CO2, that's the one where I need to move a lot of air in and out, and so I need to have the pressures and the volumes. If I say, and if the patient that's going to damage it, I mean, there's just no therapeutic range on that patient. Now this is one that if I combine it with what they call rest ventilation, providing safe levels of pressure and volume, maybe even with non-invasive ventilation, you can get the patient through, where otherwise ventilating them would have been very challenging. So I just wanted to summarize. I think ventilation therapy is in the critical care setting is new. I think it's still evolving. I think we're learning stuff all the time. A major challenge is to provide effective therapy without serious side effects. Automated closed-loop systems based on accurate physiological models may improve minute-to-minute management of ventilation patients. And I think we're going to see that. We are seeing it already. And I think our extracorporeal carbon dioxide removal coupled with lower ventilator tidal volumes and pressures, we'll see that as an evolving modality. But there's no single modalities to say this is the one that works for everybody. So with that, be happy to entertain questions.
Thank you, Dr. Roa. We understand we're going a little bit after time, but we started on purpose a little bit later because it was Friday morning. So any question, please come up to the microphone and ask if you have. Yes.
Excellent talk. I really enjoyed your talk, and you really covered a lot of areas. I have a question that I'm not sure if it's an appropriate question, but I'm going to ask it. I was wondering if the trend in optimization for the ventilation and this closed loop idea that you mentioned, is it working more toward the, and that's where I said maybe not appropriate because it may be a trade secret, but nonetheless, if you could comment on it, that would be great. Is the trend going toward the work of breathing optimization, or is it going toward more of controlling the parameters of the ventilation, such as what you mentioned, the SaO2 and so forth? Thank you very much.
Yeah, actually the research, we have active research, and I'm sure the others do too, in all of those areas you mentioned. We're definitely working on the work of breathing. We're working on pressure support, fine-tuning, working on oxygenation, and we're working on ventilation. So yeah, all of the above. And I think all of them will have a niche in this.
Is there any role for these, I've been reading about total fluid ventilators where you're using fluids to transfer oxygen and remove the carbon dioxide. Is there any role for these?
Yeah, I have to say from my standpoint, I would say the short answer is no. I'm sure somebody would argue with me. What is it, hydrofluorocarbon or something? I can't remember. I remember when there was some popular studies of that a number of years ago, and I was tracking it, and it sounded very interesting. It seems to have fallen off the map. I haven't personally seen anything recently about it. I think it ended up being a dead end unless somebody revives it with something new. And then one of the things I forgot, I didn't forget, there's too much to mention. I didn't get into high frequency ventilation. That's another modality of interest that's, again, it has some particular areas. The thing about high frequency ventilation, by the way, just throw this out, is it's one of those that's very hard to understand how in the heck it works, because you're ventilating, I mean, you know, I can't remember, like 15 hertz or something. I mean, it's just, so it's like an incredibly tiny tidal volume, which is much less than the dead space. So you shouldn't even be ventilating the patient at all. My understanding of the reason it does work is essentially what it's doing is it's increasing the diffusion. So the rate of diffusion is dramatically increased. So it's actually, you're diffusing the gases in and out.
Just ago, there was some work done on what's called noise ventilation, adding noise to the ventilator. Apparently, it gives a more biologically kind of feel to the ventilation. I'm not sure whether you know about that.
I'm not sure what you're speaking of. The closest thing I know to that, I mean, there's things like bubble CPAP where they're delivering, you know, they are adding a little oscillation. It's sort of like, what do they call it, IPPB or something, intermittent. Yeah, there are a number of techniques where you're trying to shake it a little bit. Actually, this is one we're working on as well. It's kind of similar to bubble CPAP, where you're bubbling through and you're getting these little noisy perturbations on it. The thought is it may help break up some of the secretions and other, but no, I'm not that familiar with it, other than some of the areas we're working on. Yeah.
Patients that I see hooked up to being intubated, they also tend to have IV lines pushed in them and fluids pushed in them, and it seems if you're going to do feedback control that would factor into it. So I was just wondering in your feedback control loops whether you were factoring that into it.
Oh, that's a great one. That one I think gets to where, what could we be doing? I don't know. How many of you are familiar with the IHE, healthcare, integrating the healthcare environment? Oh, really? Okay, I'm surprised. That's the whole idea of that is trying to make everything plug and play. It's been going for many, many years. It's still going. We're making some progress, but the goal would be to get all the medical devices plugged together so they're all talking to each other. Boy, we're a long way from that. So to answer your question, yes, that's what we want. I actually left some information out. I mean, some of the values I really need to do this right, I need blood gas values. I do need what the medications are on. I need all kinds of extra information about the patient that I don't normally just get. So what we really are hoping to get to at some point is where these systems do talk to each other and these algorithms do take all that into account. And by the way, just as an aside, I'm still disappointed actually, because way back when I was in graduate school, we were trying to work on indwelling, sensors that would be telling you, blood gas values continuously. Right now we still draw blood, we put it in a machine, we wait for a result, and we go back, and by then the patient's already changed. So I'm really hoping one of these days we actually get real-time blood gas analysis, because blood gas analysis is one of the key pieces of information we really need to close the loop effectively.
Okay, thank you.
Yeah.
Okay, thank you very much for all the question, and thank you, Dr. Roa, for a very nice talk. We appreciate it.